Welcome to everyone this webinar. And my co-moderator is Mr. Akil Haider from Genix Pharma. So we are starting with the introduction of a speaker. So the first speaker is my mentor. I have been mentored by her. And she is a pioneer, one of the pioneer of pediatric neurology in Pakistan, the Professor Dr. Shahnaz Ibrahim. She is a professor of pediatric and pediatric neurologist, and she is the director of Department of Pediatric Neurorehabilitation at Aga Khan University Hospital. And my second speaker is Dr. Tipu Sultan. He is a professor of pediatric and pediatric neurologist and head of Department of Pediatric Neurology at Children's Hospital, Lahore. And I must say that the Dr. Tipu Sultan and Professor Dr. Shahnaz Ibrahim has worked hard to establish the pediatric neurology in the country. And they are continually supporting their junior colleagues to play their role and learn from them. These are the two speakers of today's event. And with these speakers, we have a senior faculty members, which are the panelists of event. The Professor Dr. Salman Ali. The Professor Dr. Salman Ali served in Pakistan Army, and he has worked as a principal of Army Medical College in Rawalpindi. He's the senior most pediatrician, among the senior most pediatrician of the country. And the second, our senior faculty and panelist is Professor Dr. Iqbal Memon. Professor Iqbal Memon is a professor of pediatric, and he is a gastrohepatologist and presently working as a head of pediatric department in Sir Syed Hospital. Our another panelist is Professor Amin Gandapur from Peshawar. So Professor Amin Gandapur is a professor of pediatric, and he worked as a pediatrician in a Khyber teaching hospital. And our another panelist is, she will join us later, the Professor Dr. Salma Shaikh. She's busy in some event, so she will resume, she will join our activity soon. So this is the brief introduction of my speaker and our panelist. I would like to request the first speaker, Dr. Shahnaz Ibrahim, to start with her talk, which is related to the drug-resistant epilepsy and infantile spasm with the flagship drugs.
Assalamu alaikum, and thank you, Shazia, for your kind introduction. Shazia has done amazing and trying to establish pediatric neurology services, and she's done amazing work at NICH. She has opened up a separate unit now, and all support from her director also. So well done, Shazia, and I'm really very proud of what you're doing. So today, the topic that I was asked to present was intractable epilepsies in childhood. And this is actually a nightmare for pediatric epilepsy specialists and pediatric neurologists, because we don't have anyone who is further trained in pediatric epilepsy. So I have no conflict of interest in this presentation. I hope my voice is clear. If it isn't, Shazia, can you just raise your hand and then I'll know. So according to the Epilepsy International League Against Epilepsy, first of all, a task force of the ILAE proposed that it be defined as the failure of adequate trials of two tolerated, appropriately chosen and administered anti-seizure drugs to achieve seizure freedom. So they also recommended that now we should change the term to drug-resistant epilepsy. Traditionally, therapeutic failure of 3 anti-seizure drugs were defined as intractability, but now it's mainly 2 anti-seizure medications. And now with the many new anti-seizure drugs which are available, and every year there is a new drug which comes out, and people are trying to use it, especially the adult neurologists. And when pediatricians, pediatrics or children go to them, you realize that they've been on on all these new medications without trying the older ones. So drug trials would be recommended before determining the intractability in these particular children. And several prospective cases have shown that a likelihood of medical intractability can be identified only after 2 unsuccessful trials. As with each anti-seizure drug failure, the likelihood of successful treatment with other drugs diminishes. So if you have already tried 2, then the third one, is really not going to do anything drastic. Approximately 1/3 of patients who meet this definition will, however, achieve prolonged 12 months or more periods of seizure remission. But the risk of relapse in these individuals remain very high. And therefore, a child who has achieved remission, some form or the other, on 2 or 3 anti-epileptics, you would never, ever want to touch those and try to take him off. So what are the potential predictors? The most important is a focal seizure and a symptomatic etiology. The younger the age, and lesser than 2 years, if they have started, especially in the neonatal age, those usually are very difficult to treat. And if the seizures have been very difficult to control initially, and of course, the EEG characteristic abnormalities and a lot of these intractable epilepsies, like the continuous slow spike and wave, the Landau-Kleffner, the Lennox-Gastaut, all these have actually an EEG basis of, besides the semiology, for their diagnosis. And of course, infantile spasms also. If there is a history of febrile seizures and they go on to have afebrile seizures, then channelopathies have to be considered. And of course, if their presentations have been more than one status and there is associated neurodevelopmental delay. Now, what are the risk factors and why does somebody develop these drug resistant? So it's basically due to the lack of efficacy of the anti-seizure drug. And this is the strongest predictor for the drug resistant rather than failure due to intolerance or side effects. With each number of failed anti-seizure drug trials, we all know the risk increases. The higher the number of seizures prior to diagnosis and treatment is another consistently identified risk factor. Underlying etiology and seizure classification is also important because there are certain genetic syndromes for both generalized and localization related and cryptogenic and symptomatic for both pediatric and adult, which may, some of them, be responsible for having drug-resistant epilepsy. There are certain epilepsy syndromes, which is as we said, the earlier onset ones, which are the early neonatal myoclonic epilepsy, encephalopathy, early infantile EIEE, which is also known as the early infantile, so the myoclonic epilepsies of Dew's, and Otohara, which is the EIEE infantile spasm, especially if they are the cryptogenic ones, they are very, very difficult to treat, and the LGS if they finally convert into Rasmussen encephalitis. So medical intractability may be a feature of epilepsy at the time of presentation, or they may evolve over time. And a delayed development of intractability is most often described with epilepsy onset in childhood, particularly the mesial temporal sclerosis. And of course, as we said, the continuous slow spike in waves and epileptic encephalopathies, progressive myoclonic epilepsies, these are all the ones which will cause drug resistance. Now, individuals with drug resistance also have an increased mortality, and sudden unexplained death in epilepsy is 40 times more than those with simple epilepsy. And of course, because they happen at all times, at any time, they have a high risk of having accidents, which may be any head injury, burns, and especially the ones with Lennox-Gastaut, where they fall very suddenly. They have high tendency of head injuries, and sometimes in these children we tell them to wear a helmet actually because they are so frequent, and you don't know when it's going to happen. The child is 4 or 5 and is walking around, and it's very difficult to control these children, and they fall down and suddenly hit their head. So sometimes, wearing a helmet is the only thing that will protect them. And then, of course, the quality of life, poor academics, social isolation, are all the complications that can take place in these children. The cumulative death, according to the cause of epilepsy, as we see, the cumulative rate of death in the remote symptomatic causes go higher as the age increases. And if it's idiopathic, then it's much lower as compared to the remote symptomatic. Differential diagnosis is very important. And you have to figure out what is the reason for failure in these children when they're not responding to medication. And the most important is the correct diagnosis. So it's important that you make a correct diagnosis first of seizures. And the most important in pediatric age group are the pseudo seizures. And we see these young girls who come in with 1, 2, 3 medications, and they keep on having seizures. So sometimes pseudo seizures may be added on top. And of course, inappropriate dosages is very important, because in pediatrics, we are very, very strict with dosages. And there is no such thing as ek chamach, ya adi chamach, ya paun chamach. We have to be very specific about how we are giving the dosages, and 99% of all, or in fact 100% of us will use a syringe to tell them that this is how you use it. And you cannot at any time use a syrup spoon, even if it is coming in the bottle. So non-compliance, a lot of times non-compliance is not by not giving the medication, but inappropriate timings. And when you don't give it at the appropriate time, we are already using them on an extensive time, because we don't have long-acting ones. And therefore, if you're using it, a drug which is supposed to be used 8-hourly, you're using it at BID dosages, then you have to be very strict with the timing. And of course, a sleep deprivation. This is one of the most important things in Karachi. What I have seen, whether they come from even Sindh, now Hyderabad, they do not sleep before 12 o'clock. And nowadays with this corona, the last year has been disastrous. They sleep not before 2 o'clock, and they get up at 2 thinking that that's enough. So you have to counsel them on the sleep hygiene and the sleep practices, no using the mobile phones, no using iPads. And so those are important. We've discussed the psychogenic because they happen in a lot of epileptic individuals. And the non-epileptic paroxysmal disorders can be mistaken, like sleep disorders. So you may have movements. A lot of times they bring videos, and that is very helpful for us to differentiate whether those are seizures or whether they are sleep disorders. And this is exactly what I was saying. So you have to differentiate the non-epileptic with epileptic, and then come out with why they are being provoked, and if they are unprovoked, and whether they are focal or whether they are generalized. So how would you monitor them? How would you evaluate them? You would do a video EEG monitoring, and this is, we are lucky because we have it, and I think Tipu also has started the video EEG monitoring some years ago, and maybe at NICH we will establish one very soon. Neuroimaging, of course, metabolic testing, which is now available all over Pakistan, which is at least the preliminary metabolic testing, and then the seizure diaries. And I will add something which is genetic testing over here, which is now the new investigation, which we are jumping before a lot of other investigations. So therefore, if you're the primary physician and this is a new onset seizure, they will become persistent in 40%. And then you will need the video EEG to differentiate between what type it is, whether it is truly epileptic, and whether there is a focal epilepsy. And if it is, then you would need the MRI for epilepsy protocol. And if there is a focal and he is intractable, then the earlier referral for surgery is what is required. And if it is non-epileptic, then you would just manage depending upon what the condition is. Despite all this, they will still be medically intractable in almost 30% of cases. Now, video EEG monitoring refers to continuous monitoring while you are having a recording also. And it is very, very helpful because, you know, this is, everything has a cost to it. So a 24-hour video EEG over here will cost you something like almost 30,000 rupees. If you're having seizures every day, then this would be the optimum choice for you. And especially if your EEG is not picking up anything and you are having a normal record, or you are having something which is not explained by what the semiology of the seizures are. So therefore, it is important. Recently, I had a child who was having breath holding attacks. Now, this is a 1-year-old child, and we did the EEG. And interestingly, they are all provoked. Every time the child cries, he has a seizure, and he has a tonic seizure. He holds his breath, goes back, head back, and the EEG goes flat. And so because of the hypoxia, he goes flat. And so it was very classic to see that, but every episode was provoked. So, you know, sometimes the parents are so hyped up that you have to get these done. And it was very difficult to hold anti-epileptics in that particular child because of the fact that they kept seeing these seizures that he was having, thinking that that will cause brain damage. So, you know, you do it to see whether these are or these are not, and what type is it, where is it coming from. Another very intractable patient that I recently saw, we did the video EEG. The semiology was classically frontal lobe epilepsy, and you could see on the EEG that every time he had the seizure, they were starting from the central and the frontal area. So this was classically, and it was nocturnal, and so it was what we call the autosomal dominant nocturnal frontal lobe epilepsies, and then you'd know what kind of anti-epileptics would be beneficial to these children. In neuroimaging, you do what is called the epilepsy protocol, and you have to do it because they will do thin cuts to the mesial temporal area and the hippocampus. And sometimes you may want to do it for autoimmune encephalitis also, and neoplastic images. But the non-specific findings you should know. There is no such thing as, you know, it's not an etiology to say that it's diffuse atrophy. And later on, when you're thinking about surgery, PET can be done. We can do PET over here now, but we can't do SPECT and magnetic source imagings. Seizure diaries are very, very helpful because that will give you, especially in infantile spasm, because there is no way for you to know whether the child is improving or not. Because if you're having 50 to 100 seizures a day, coming down to 80 will not be objectively appreciated by the parents. And therefore, they will keep coming back and saying, oh, ji, kam nahi hue, kam nahi hue, kam nahi hue, until you actually count them and tell them, see, there is a difference that is happening. And of course, the amount and quality of sleep, timing of medications, and everything have to be recorded. Especially now that we're doing the ketogenic diet, we are keeping a strict record of these, which is very important. Now, metabolic testing, we've also started, let me tell you, the biotinidase levels now here, and autoantibody evaluations are being done. And genetic testing, which is the new generation next generation sequencing, which is targeted for epilepsy panels. And we have now identified a whole bunch of these, and I have almost all of these patients that I'm following in my clinic. So knowing the type of genetics is very helpful for prognosis as well as deciding the type of medications. Now, treatment, anti-seizure drugs, surgery, vagal nerve, ketogenic, and other therapies. So it is important to review the past treatment that you have done with these children, and what are the drugs that you have used, and the compliance, as we already said. And so you need to see which ones were the first ones added, which ones were the second, and how much remission did you achieve with each drug. Sometimes you see patients who are not being controlled, but 3 drugs have been started at one go, and you don't know which one really would make a difference to them. So in those conditions, you have to try to target the type of epilepsy so that you can take off one. Sometimes they can aggravate. The anti-epileptics can sometimes make it worse. For example, if it's a myoclonic epilepsy and somebody has given them carbamazepine, it's surely going to make it worse. Absence is going to make it worse. So you need to know, and sodium channelopathies, if you have started lamotrigine, then that's going to make it worse. So, you know, you need to know the mechanism of action of the drugs also. They're not just, you know, drugs that you use like Calpol. So, and reduction in severity also improves the patient's quality. Now, the drugs which are broad range, we all know, is valproate for us, even topiramate, and levetiracetam. Lamotrigine also has a relatively, you know, more wider range, and the benzos are very good when we add them on. And the narrow spectrums are the Lilap, lacusamides, gabapentins, even vigabatrin is more for focal epilepsies, and especially if you're not getting controlled on oxcarb, then there is definite recommendation of using vigabatrin. Ethosuximide has got a very narrow spectrum and is only the drug to be used in cases of absence. There is no other epilepsy where you would use ethosuximide. Unfortunately, ethosuximide is not available for us very easily, and therefore we end up using valproate or levetiracetam. So this is the mechanism of action. Just to let you know that the levetiracetam has predominantly an SV2A. The rest, which is topiramate, phenytoin, and your lamotrigine, lacosamide, they are all sodium channel, and carbamazepine. So if you use 2 or 3 of sodium channel, they're going to make it worse. So you need to understand that, you know, if somebody is on 5 anti-epileptics and they're all acting through this, then that's not going to really help. You have to choose a medication which has another mode of action. So the valproate has got both calcium and sodium, as well as it is an inhibitory transmitter. There are some which is excitatory and which is perampanel, and also topiramate, which has some excitatory activity, and it is predominantly as carbonic anhydrase inhibitor along with zonisamide, which is then you need to monitor their electrolytes very frequently and the eye pressures. Surgery is another way of dealing with intractable epilepsies, and it is if you identify the epileptogenic focus. Is underutilized in our part of the world, especially, and best is for lesional temporal lobe epilepsy. And you know, you have if you have a concordance with MRI and EEG, and if you have a left temporal lobe discharge or a right temporal lobe, and you see a focus, and it's not his dominant lobe for speech, because that has to be evaluated. Otherwise, you will end up with no speech in the child with seizures in remission. So patients with non-lesional, they are also doing it, and they're using MEG now in Canada, where they identify the focus, but actually you don't see the focus on an MRI. But they are, you know, especially the intractable ones, where they really quality of life is very impaired because of it. So if you have any focal lesion like malformation, tumors, so of course they will come out. Sometimes people have gone after TS also, and they have tried to remove the tubers. And but it is better to identify the one which is causing the highest, you know, discharges, and then you may want to get this removed. Cortical dysplastic lesions and gliosis also may be amenable to actually removal. So we normally think, oh, gee, scar ho gaya hai, and what do you want to do? But if it's the area which is discharging, then you might want to go and, you know, surgically remove that. Then there are certain palliative surgeries, especially in Rasmussen's, where hemispherotomy or hemispherectomies, especially in atonic seizures, the corpus callosotomies would be done. And these are, and TS, you can also, as I said, lobar and multi-lobar resections have been tried. Callosotomies and LGS, because in LGS what happens is the focus where it is coming from spreads so rapidly through the corpus callosum that you drop down, and it is the drop which is which will be stopped, not the seizure, if you do a callosotomy. But the head injuries and you know, they will be stopped. Now the recent most things which people do is subpial resections, and they use vertical incisions in the gray matter at 4 millimeters interval to limit the propagation of epileptic activity, but without disturbing the functional integrity. This is a very interesting case where there was a 10-year-old child who came in after a road traffic accident, and then 2 years later came with, at 10 years had a concussion, and then at 18 years started having seizures. Now this was the MRI where there was a focal sort of a scar tissue in the left frontal area, and but when the EEG was done, it showed sorry, the EEG showed sharp waves over the right temporal anterior temporal region. And when they did a FLAIR image and they did a repeat MRI with thin cuts, they found that the right temporal had the medial temporal sclerosis, and then they did put in-depth electrodes, and they did recording, which is ECOGs, which is electrocorticography, and they found the discharges to be occurring from this place rather than the scar. They went and did the surgical removal for this place. So it's very important to identify the point. Every tissue which looks abnormal may not be the one that is discharging. So then there is vagal nerve stimulation. This is also very good for Lennox-Gastaut and atonic seizures, and especially they reduce the frequency by almost 40 to 50%. Then you also have cortical stimulation. Actually, brainstem, deep brain stimulation has started over here, and it's also been done in Lahore, I've heard, but that's basically for dystonia. And they actually, when you cannot do resective surgery, then you tend to put in these probes into the eloquent coat, wherever the epilepsy is originating from, and then they try to, it's a closed loop cortical stimulation where it tends to then inhibit the time when the discharge occurs. And so is the same for the deep brain stimulation. I'm going a little faster, but this is basically a very good way of dealing with how you would deal with it. So if you are, as you go on from generalized epilepsy to extratemporal and temporal, you may go on to lesionectomies, and surgery would be something that you would want to do. Now, the ketogenic diet is something that we have started over here. Dr. Tipu has also started, and Nusrat has also started in Multan. This is, was first actually identified by an osteopath, and he thought that, in 1921, where believed the seizures were due to intoxication of the Peyer's patches, and it was something in the gut, and therefore, if you rest it, you would get seizure control, and he did. Later on, it was developed in Johns Hopkins, and the first classic was the 4:1. But in the late 40s and 50s, because of the phenytoin and phenobarb, people stopped using it. Now it's come back again. There are various theories, and they say that ketosis, because ketone bodies are utilized by the brain, then increasing the ketones will somehow be an inhibitory effect. And cause the change in the seizure threshold. There are different kinds: the classic, the medium chain triglycerides, the modified Atkins, and the low glycemic diet index. And these are the different ratios. I'm not going to go into great detail, but you can see that even a 50% decrease in seizures is something which is very, very appreciated by the parents. Because if you're having 100 seizures, then your seizure control, you may not achieve 100%, but even 50% is something which you can achieve with keto. And I have seen, this is my data, which 83% of my patients actually achieved more than 50% control in their seizures on the classic KD. So cannabinoids, this is again something new that has come up, and I am a little skeptical because we don't have the pure form available, and there are legal restrictions to this. But it is very good for a couple of types of epilepsy, especially the LGS and the DRE. DRE is actually, it's a kind of epilepsy which is caused by a particular type of genes, especially the common ones. And this is the commonest type of epilepsy, which is due to the sodium channel 1, SCN1A. And why does it have sometimes DRE is when you have intractable epilepsy with intellectual delay. But it can also cause simple febrile seizures, and starts off as febrile seizures, and then they start having afebrile seizures. Particularly important to remember in these is that they have to be kept cool. And so the summer months in our country are really horrifying for them. Now, cannabinoids have been shown to be effective in Dravet syndrome, and the mean reduction in seizures at 12 and 96 weeks was almost 50% in this. But they do have a lot of diarrhea and drowsiness, and therefore that limits the use. IVIG, new onset refractory status, especially, may be one that you can think about using it, and desperate people do desperate things, and you think about immune modulated mechanisms, especially the NAMDA or post-viral encephalitis would be one that would be responding to this. ACTH, its most role is in continuous slow spike and wave. Now, this is another type of difficult epilepsy which happens only at night. And if you do the EEG in an awake EEG, will be normal. But if you do it in sleep, there will be continuous discharges happening. And steroids, they do tend to respond to steroids. So, but a clinician using steroids in childhood epilepsies other than infantile spasms should take this into account, that there is no new evidence for in the other forms of childhood epilepsies. Micronutrient dependent seizures. Now, this is very important for us to know that a lot of neonates present with seizures, and they can be simply pyridoxine dependent seizures. And I have a very classic example of a child who was given levetiracetam and also started vitamin B6, because we always start B6 along with vitamin B lirase. Eventually, we tapered off the lirase, but the B6, the parents refused to stop. And because of that, the child remains seizure-free. Every time I counsel the parents, oh, there's no need for B6, they would be very hesitant. Once they actually stopped it, and the child started having seizures again, and then they restarted it. That child was ALDH7A1. Now, this is an anticotin gene, which is an enzyme required for lysine degradation. Actually, what happens is that when the lysine doesn't go under degradation, the intermediary, which is the AASA, affects the pyridoxine and reacts with the pyridoxal P-phosphate, and therefore causes it to be inactivated. And B6, therefore, is a cofactor in a lot of these enzyme modulations, and therefore results in seizures. So it usually happens in the early neonate. Intellectual disability is common, even in patients with who receive vitamin B6. But you need to make sure that they are on low lysine, and arginine has to be supplemented for them because of that metabolic pathway. And if you don't give arginine, then there is associated intellectual disability. Biotin, we all know, and nowadays we can do the test. And so if you are suspicious of biotinidase deficiency or holocarboxylase deficiencies, then there's no harm in starting them off. Particularly very easily to detect in the early neonate, because they have this classic seborrheic-like rash. They don't have hair on top. They don't have eyebrows and lashes, and the lactate is high. And so because biotinidase will not be affected by giving biotin, because it's an enzyme, and you replace the biotin, and that will, sort of cover up for the biotinidase, which is not working to bring back the biotin, the endogenous biotin. It can be sent on Guthrie, and if you treat it early, there is no neurological handicap. But if it is not treated, they tend to cause significant neurological handicap, especially with hearing, and they can become deaf for life. Now, this is something that I really, think that is the next way for neurologists, and will be on the click of a button, where we just send a heel prick like this, and where you can get all these genes on a panel. Interestingly, so SCN1A, it's a loss of function of SCN1, like the sodium channel. And therefore, if you give them sodium channel blockers like carbamazepine and lamotrigine, they will get worse. Now, in SCN2A, they are actually controlled with sodium channel blockers. So these are important for you to know, because if you give these, then they will be helped. And if you give these over here on the other one, they will get worse. Then there are other channelopathies, like I said, that this is autosomal dominant nocturnal frontal lobe epilepsies, which is the KCNT1. Of course, the calcium channel ones, the Cherna ones also cause this adenphale. And then you have very, very interesting, which is called the multiple migratory focal seizures of infancy, MMFSI. It is very, very interesting to see this EEG because the EEG pattern will be changing. At one time, they will be at one point, and then the other point will be at another point. Interestingly, I diagnosed one of my cases on the basis of the EEG, and the genetic study came out to be KCNT1. They tend to respond to quinidine. And so sometimes if you have a KCNT1, then quinidine may be, but of course you need to monitor it and you need to really follow because it's a cardiac anti-arrhythmic, it may cause cardiac arrhythmias. And giving it to neonates may be not something easy. Again, the KCNQ2 can cause benign familial neonatal epilepsies, 2 epileptic encephalopathy. And usually the inherited ones are the benign ones and the de novo ones are the difficult ones. The same gene causing 2 different variations. So precision medicine is where we stand now. And medicine for most human history has been one size fits all. But we are finding the diseases we have lumped together under one label are actually at a molecular level quite different. And therefore, precision medicine tries to understand what's underneath those disease layers and tries to not to lump everyone together, but to think about individual differences. This is from Francis Collins from the Human Genome Project. And I thought this was very, very, appropriate for where we are heading, not only in neurology, but almost all disorders. So just the last slide where you would need a lot of other associated support for these individuals, lifestyle modifications, psychosocial impact, behavior and psychiatric comorbidities have to be addressed, and long-term side effects of the drugs have to be addressed. You need a multidisciplinary approach, you need a specialized nurse, you need public support, you need advocacy groups, and you need collaboration with medical and psychiatric subspecialties. Thank you very much. And I think we'll take questions at the end.
A nice and detailed talk on this difficult topic, which is very difficult to manage by a pediatric neurologist. So before taking questions, I would like to request the participants, please do share your questions in a chat box so that we can answer. And I would like to request the panelists, 2 of the senior panelists, Professor Salman Ali and Professor Iqbal Memon, if they want to have their questions to be discussed over here or they want to have their input to be shared.
Yes, thank you very much. I think Dr. Shahnaz has given a very, very elaborate overview of the drug-resistant epilepsies in children, and particularly the difficult epileptic syndromes, and especially the genetic implications and the genetic guidance regarding the treatment of these difficult to treat epilepsies. And I think for the benefit of the general pediatricians, it should be very clear we are talking of epilepsies, not epilepsy, because in general practice people just say epilepsy, they just take it as one disorder, you know, but basically we have seen that every epilepsy is different. And as Dr. Shahnaz pointed out, in precision medicine, you go down to the molecular level and you see so much implications of that for therapeutic purposes. I think this was a very, very nice elaboration of a very, very difficult subject. And this must have benefited all of our participants, the pediatricians who are attending this important session. And pediatric neurology definitely forms a very large part of the practice of the general pediatrician, because we have got a dearth of pediatric neurologists, and pediatric neurology departments are now coming up in major cities and in our major children's hospitals. And I think from these pioneers of pediatric neurology here, this is a very, very important interactive session, which would benefit all. And I think people would have many questions, and I would request Professor Iqbal Memon to give his input regarding this very difficult subject. Thank you very much.
Thank you very much. Assalamu alaikum. I think first of all, I should compliment Shahnaz for a lovely overview of a very, very difficult scenario. I agree with Professor Salman that this topic is at least definitely a learning process for me also. We know that this subspecialty of pediatrics has really grown rather fast, but recently. And the common misconception has been elaborated, that is, the epilepsy is just not one disease, it's a multitude. There's an entire book actually for this sort of disorder, and making a proper evaluation, utilization of drugs, selection of drugs, dosing of drugs, and then monitoring, then getting the investigations done. And in the event we are stuck anywhere, I think it is always good to seek help from experts in this field. And Alhamdulillah, we do have now growing reference centers for this area. And that's what will make it nicer for our patients. And certainly must compliment Genix for managing this kind of webinar. We used to have general pediatric topics and then cover the epilepsy in one talk. But this, you can see that how well it has evolved into a huge subject, and with a lot of differentiations and parameters to be taken care of. So I appreciate, I think we will certainly be learning more with more questions coming in, and elaboration that will come through the experts here with Shahnaz and Tipu talking to us later. Thank you very much for having us on board, and we'll be participating through for questions as they come by.
Thank you so much, Professor Iqbal Memon. So I think we will take the question answer at the end of this second talk. Now I request Dr. Professor Tipu Sultan to start with his talk related to this drug-resistant epilepsy.
Thank you, Dr. Shazia. So I'll speak with this first slide. So infantile spasm. So this is the Department of Pediatric Neurology. During one of the past International Epilepsy Day. So I'll start with this brief video clip. This 4-month-old infant presented to one of the colleagues with these subtle movements and initially labeled as abdominal colic. And perhaps this is one of the most difficult thing to pick this right at outset, because earlier the diagnosis better would be the prognosis in case of infantile spasms. So subsequently, because of the repeated movements and recording by a smart mom, turned to be a case of infantile spasm and referred to Children's Hospital Neurology Department. As I mentioned before, these are the initial ictal manifestation in all these infantile spasms. And this is the EEG manifestation called as hypsarrhythmia. So I was at this particular slide in which I was mentioning about the incorporation of epilepsy syndrome in the latest classification of ILAE. So West syndrome is a triad of infantile spasm, which is a clinical seizure, along with specific EEG pattern called as hypsarrhythmia and developmental delay. However, in the later classification by the consensus group, even 2 components out of these 3 would be sufficient to label a child as West syndrome. So combination of infantile spasm along with this specific EEG pattern called as hypsarrhythmia would be a child either called as infantile spasm or West syndrome. By definition, West syndrome is one of the most common epilepsy syndrome within epilepsy syndrome and within pediatric neurology practice. It was initially diagnosed and labeled by an English physician, William James West, way back in 1793, in the 18th century, who first described this in his own son. And that's why this syndrome was subsequently labeled as West syndrome. This syndrome is age-related, generally occurring between 3rd and 12th month. There are many reasons. At the moment, we have a long list for subsequent classification of this West syndrome. And syndrome is often caused by an organic cause within the brain, which may be either prenatal, perinatal, or maybe postnatal. Yet, in many cases, still we are not able to identify a specific cause. However, there are many hypotheses, and one of the most appropriate would be malfunction of neurotransmitter function, and precisely for the regulation of GABA transmission process. Subsequently, it led to hyperproduction of the corticotropin releasing hormone, and that's why high-dose steroids is one of the most common practice to treat these infantile spasms. Clinical presentations are either one or maybe combination of all these. It could be lightning attacks or nodding attacks or slam seizure, as I have shown you in my initial video clip. These are sudden, severe myoclonic convulsions of the entire body. At times, these movements are in clusters. Convulsions of the throat and neck flexor muscles, during which the chin is little forward towards the chest, is perhaps most common clinical presentation. As initially mentioned by Professor Shahnaz, there have been various genes identified not only for all intractable epilepsies, but also for this infantile spasm or West syndrome. However, tuberous sclerosis complex is perhaps one of the most commonly associated neurocutaneous syndrome, maybe in up to 30% children. In the recent years, we have been able to identify many brain malformations which are associated with these infantile spasms because of the high quality imaging techniques. Globally, prevalence is about 1 into 3,200 up to 3,500 live births, and boys are relatively likely to have this syndrome. Classically, we classify infantile spasm or West syndrome into two groups. As I mentioned before, if we are able to identify the cause, these are called symptomatic, as attacks are a manifestation of an underlying symptom. And this is a long list of underlying causes who are subsequently causing infantile spasm, and these include cortical dysplasias and lysencephalys, schizencephalys, and many of the other vascular malformation, some of the syndromes like Sturge-Weber syndrome and other neurocutaneous syndromes, and some common inborn errors of metabolism. However, in a reasonable number of cases, we may not be able to identify exact cause. In that particular case, we may label this as cryptogenic. In this particular group, genetic causes would be the likely reason, and that's why in the later classification, cryptogenic and idiopathics are more or less considered the same group, and hence we divided these West syndrome into either cryptogenic or symptomatic. As I mentioned before, tuberous sclerosis complex is one of the most common group which is associated with infantile spasm, and it's a complex disorder which not only involves brain but also heart, kidney, lungs, and other areas of the body, and that's why it's now called as tuberous sclerosis complex, in which we may have lesion in different part of the body. And this is the pictorial presentation of all these lesions present in different parts of the body. So these are some of the pictures which we have taken from our own patient groups, in which you can easily identify hypomelanotic patches and adenomas on the face of children. Infantile spasm is also very much common in Down syndrome. So West syndrome appear up to 5% infants with Down syndrome. As initially mentioned, it is difficult to treat even in these children because of many other associated problems. So now I'll come to the last but the most important component of my presentation, that is the management of these infantile spasm or children with West syndrome. This particular syndrome is challenging task for both pediatricians as well as child neurologists. Should be diagnosed as early as possible. Based on what is known today, the prognosis depends mainly on the underlying cause and the attacks and the duration at which we were able to diagnose exactly. Prognosis is more worse when patient does not respond to therapy, because still there is a reasonable number of group who didn't respond to initial anti-epileptic drugs, and treatment differs in patient to patient. There are two standard mode of treatment globally, which are vigabatrin as well as ACTS, steroids. Vigabatrin, which is approved globally way back in early 2000 and subsequently in US, is now almost approved everywhere and recently approved in Pakistan as well. This is a drug of choice for treating infantile spasm. However, there are definite side effect profile as in any other drug, which includes somnolence, headache, dizziness, fatigue, weight gain, decreased VN, and other changes. So vigabatrin is not only a drug of choice for managing infantile spasm, but also a #1 choice for managing children with tuberous sclerosis. However, there is one potential side effect, which is loss of peripheral VN. So one should always be very cautious while prescribing this drug and subsequent regular monitoring of VN. However, the latest data proves that it's fairly safe. The good point is it's fairly safe for managing children with the infantile spasm for 6 months up to 12 months. It is indicated as monotherapy for children from 1 month up to 2 years with infantile spasm. Precise mechanism of action is though not very clear. However, the proposed mechanism of action suggests that it's an irreversible inhibitor of gamma aminobutyric acid transaminases. So these GABA transaminases metabolizes GABA, which is an inhibitory neurotransmitter, thereby increasing CNS GABA levels. So that's why it works very well in children with infantile spasm, particularly children with tuberous sclerosis complex. And for the past almost a decade since its approval by FDA in 2009, its usage increases and experience is vast about its efficacy in children with infantile spasm or with tuberous sclerosis complex. The second choice is ACTS. Of course, this drug is again a drug of first choice in comparison with the vigabatrin. However, yet this is not approved and easily available in Pakistan. There are, of course, side effects like many other drugs, weight gain, especially in the trunk and face, hypertension, some of the metabolic abnormalities, and irritability, septicemia, and heart failure. In cases of poor control after these first two options, which include steroids as well as vigabatrin, the remaining options are, as mentioned by Professor Shahnaz, pyridoxine, valproate, topiramate, levetiracetam, lamotrigine, and zonisamide. Pyridoxine was considered as a drug of choice in Asia Pacific, particularly in Japan. And they put all children with infantile spasm to begin with on paradoxin. And it was also a case shared by Professor Shahnaz. And there was also one case in our practice as well, in which, though we don't have the facility for genetic testing, however, on the clinical grounds, we put the child on B6 and subsequently nicely responding to it. So after failure of all these drugs, then we are left with ketogenic diet and some other remaining option. But in our experience, almost 80% children nicely responding to either one or other drug. So in that particular case, prognosis varies from patient to patient. It's difficult to comment right at outset because of the wide range of etiology, severity of sign and symptom, and therapeutic choice. Of course, idiopathic infantile spasm shows more favorable prognosis as compared to symptomatic patients. In contrast, those who have significant comorbid condition, including developmental delays, behavioral and psychological problems, bad imaging, and other conditions, the prognosis would be difficult to comment at the outset, however, generally not very good. In about half of the children, they may develop subsequently Lennox-Gastaut syndrome. These are some of the new modalities as mentioned by in the previous talk, the ketogenic diet as well as CBD oil. This was the book developed by our department for those children who are on ketogenic diet. So written by our colleagues in Urdu for the guidance of patients and patients' families. So what is the future for managing these children? In initial discussion, Professor Shahnaz also mentioned about VNS, epilepsy surgery, transplant, DBS, gene therapy, which are generally recommended for drug-resistant epilepsy. However, still there are trials going on some of the new anti-epileptic drugs, which includes rapamycin and neuroactive steroid for those group of children in which still we are not able to give 100% seizure freedom with children of infantile spasm or West syndrome. So in summary, West syndrome is an age-dependent one of the drug-resistant epilepsy syndrome. Classical presentation is between 4 to 9 months of age. Seizure types are generally epileptic spasm. These the associated EEG pattern is called hypsrhythmia, and common etiology includes some of the genetics and acquired causes. So that's why we may call it as polygenic multifactorial. Treatment choices are starting from vigabatrin, which is now available and registered as a registered drug, and also includes ACTH, oral prednisolone, benzodiazepines, valproate sodium, levetiracetam, and topiramate. Prognosis is quite variable and dependent solely on the underlying etiology. So this was one of the publication, one of an article published in last year, JICNA Journal of International Child Neurology Association, which was experience of children treating in Child Neurology Department, Children's Hospital, Lahore. And my last slide will be management of status at home, because there is likely possibility to have a development of generalized epilepsies in these children who are not controlled during the initial few months of management. So I will stop here and invite comments from the panel of experts, and over to Shazia.
Thank you, Dr. Tipu Sultan. It was very nice and informative talk with a very detailed overview about pharmacotherapy of infantile spasm and non-pharmacological options. I think it helps a lot to me as a pediatric neurologist and other participants also. So I would like to welcome on board our panelist and speaker. I would like to take a comments from Professor Amin Gandapur, if he would like to share his views about the talk, and thereafter we can take a question and answers from the participants.
for giving us the opportunity to listen first to such a elaborate and very comprehensive presentation by Professor Shahnaz and Tipu Sultan. I think we all are educated because we practice general pediatrics more often, and neurology is always, when I see a child with a neurological problem, I'm a little stunned with that, and is sometimes really difficult for us to manage such situations. Well, the talks are elaborate and very comprehensive, and thank you again. I would be taking the liberty to ask one or two questions for the benefit of all participants. And one is that many times we get children that they are on 3 or 4 anti-epileptic drugs and the fits are controlled. And then you feel sometime that after some time, you need to taper off these drugs. So if there is any key or clue how to taper off, when to taper off. And a second question, for all of us is that when to stop the treatment of epilepsy when they are fit-free, for example, for the last 2 years or more. So these are my questions, and well, the talks are very elaborate, and thank you once again.
Thank you, Professor Amin. I think these are very, very relevant questions. But there is a whole topic that can be discussed on when to start and when to stop. So there is a whole, it's a whole presentation for when to start and when to stop. But your question about when they are already on 3 and 4 and they have stopped the seizures. So this is again, first of all, you would want to know, were all of them started at the same time? And sometimes that's the case also. So, the doctors are so enthusiastic, after one seizure, they will put them on 2 drugs. And then they are on that for going on and on and on. Of course, those are the easy ones. But somebody who's on 4 or 5, then definitely there was a time period where they were added on. And if they are seizure-free for a year, I would be very hesitant to take off anything. But if they are seizure-free for a year and they are improving in their development, whatever the level, I'm not saying that you would want them to be running around if they are only sitting, but at least some sort of cognitive ability. Maybe they've started smiling, whatever the age, or having some eye contact. And so some improvement taking place over time. Then you would see which one was the first and which one was the last. And then you would ask the parents, kaun se aapko zyada farak laga tha? And so assuming that the last one was one that actually hit it. So you would want to take off the first one, which probably didn't do much. But I would go very, very slowly. Normally they say that you need to taper over at least 6 weeks, but I go much slower, especially in these intractable ones. And you also have to see the EEG. If the EEG is something like a continuous slow spike in wave or a Lennox-Gastaut, which doesn't get better, I would not touch him. I would, and if the EEG is still showing the same things, they are very thinly balanced. So maybe they've reached that balance, and therefore you would not want to do much, try to take him off. So if the EEG is way better or, sort of improved, then this is particularly the way that I go. So I would take off the first and then see how he goes and then take off the second. And usually I try to take off the benzos first, because benzos are very, develop a tolerance. So the efficacy of anti-epilepsy is usually like an add-on. So if somebody is not getting controlled, I would put a benzo on till the next anti-epileptic takes on. So like Frisium is really very good, like clobazam. And therefore that now it's available since the last 2-3 years. Previously we didn't have it. So therefore there's a question about Rivotril, when would you add? So that would be like an add-on. It would be my first line drug. Benzos are never a first line drug. And therefore, when I want to take it off, either if the child is over 2 or 3 and he's still on phenobarb, then that would go. So those are the ways that I would go. And so that would be the way that I would try to taper it off. Tipu can also share his thoughts with it.
I think Professor Shahnaz completely elaborate her experience in managing children with difficult epilepsies and subsequently tapering these anti-epileptic drugs. So probably it is really difficult to stop or discontinue or even reduce around 1 year. Maybe 2 years would be more appropriate in completely controlled epilepsy. What do you think, Professor Shahnaz? I think
no, I agree. No, I agree. 2 years is what is standard, is said. But you know, when somebody you don't know exactly, you know, kam as kam 1 saal is yeah. What I would, you know, not less than that. So if they've come to you and they say कि आपने 6 महीने से जी नहीं हुआ है, आप हटाएं, I would not touch it.
Generally, मेरी भी कोशिश यही होती है कि ये काम कोई और कर ले, क्योंकि उसमें रिस्क होता है, क्योंकि फिर क्योंकि because it's really difficult to stop anti-epileptic drug after 6 months or 1 year period, because in the current practice, neither it's recommended nor it's wise to invite a problem, because nowadays parents are very skeptical for having a seizure of their children.
I request to the seniors, most of our participants are pediatricians.
I think we would like to take opinion from General Salman, because he has a lot of experience in treating children with different epilepsy syndromes and drug-resistant epilepsies. General Salman, please, would you like to comment? Managing children with West syndrome and infantile spasms.
Yes, thank you, Professor Tipu and Professor Shahnaz. I think you have elaborated the problem of drug resistance and the difficult to treat epilepsies, particularly West syndrome, very well. And the question of Professor Amin Jan regarding the stoppage of anti-epileptic drugs, I think your comment is very, very appropriate. I usually tell my trainees, if they come with such a problem that there are 4 anti-epileptics and which one to stop. And if they tell me the child is wet controlled, so I tell them by panganalois. Because if you just fiddle, then if this child starts, you know, again, seizuring again, then you don't know how to control them. So I think that is the general principle is the drugs on which you have controlled, whether with the single monotherapy or polypharmacy, I think it should be continued for at least 2 years before, you know, you think of tapering. And particularly the pediatric epilepsy syndromes, you know, these are peculiar to pediatrics. And, you know, 75% of all epilepsies are occurring in the pediatric age group. So basically, therefore, epileptology becomes a pediatric subject, and particularly the type of syndromes like the infantile spasm, the Lennox-Gastaut. These are the ones which are seen by pediatricians only. So therefore, the pediatric neurologists are mainly, I mean, the lead epileptologists also. But of course, the various syndromes, we have seen the West syndrome, the Dravet syndrome, and the various infantile epileptic encephalopathies. These are, of course, quite common here, and they hover around to pediatricians and pediatric neurologists. And I think, as Dr. Shahnaz has pointed out, we have got many genetic epilepsies, and we need to really work on the genetics also, as well as the therapeutics. And I think with the therapeutic options now open, particularly in drug-resistant epilepsies, our pediatricians with the pediatric neurology departments in our various hospitals active, I think we should be better able to now control these difficult epilepsies. And fortunately, we have got these online facilities available. You can Zoom, you can use the FaceTime, you can talk to any, I think, expert in pediatric neurology anytime. So I think our pediatricians have got the opportunity to really take on these problems, and they need to understand that these are all, the epileptic syndromes are all, as you very much highlighted in your lecture, the new classification, that the epileptic syndromes are totally a different class, and they are classed as different in the classification of epilepsies, and among them the neonatal epileptic syndromes, which persists into infancy and beyond. So I think all these things are very, very important. And we see that the subtle epilepsies, which are particularly very, very important to recognize, particularly in infancy, as I mean, your own case, Professor Tipu, you depicted this so-called infantile colic, which labeled as infantile colic. So many of the fits with children with excessive crying. So it's very important to recognize and do the EEGs and look at the videos, which is now available. Parents are now coming. So I think with these options available, with better diagnosis, we can really hope that we will be better able to manage these difficult to treat epilepsies in the future. So overall, I think both of you, Professor Shahnaz and Professor Tipu, our lead experts in pediatric neurology, have highlighted the problem very, very well. And I think the magnitude of the problem and the therapeutic challenges which you have pointed out, and I think they are well taken by our pediatric community. I think they would be we are well educated, and they would be going home better able to really manage the problems which they are facing. Thank you very much. I think Professor Iqbal Memon is on the screen and he is itching to speak, so I should give them an opportunity to speak. Thank you very much.
Yes, sir, I have been more keen to listen to the wise words from lovely friends over there. And I think if I have the option to say a few words more, and that is, I think this kind of a talk with subspecialties talks and subject which is actually expanding exponentially. We should have some more seminars like this, and we must compliment not only the speakers who have done a fantastic job, but the sponsor who has come up with this webinar. Number two, I think learning again and again and more as these things are expanding should be very welcome. And every doctor, particularly pediatricians who live with epilepsies or seizure disorders time and again, must keep on relearning more of it as it comes. But I think we should take a couple of points at home. One, very well elaborated, that the drugs should be taken off when they come about very slowly. Now, I knew that was to be slowly, but I learned just now that they should take not about 4 to 6 weeks, but even more, longer, and so go very slow. Secondly, that every time you have a seizure activity with a child, you should think about proper diagnosis. And there will be possibly other reasons for those presentations and syndromes particularly. And thirdly, take help from experts as available. And Professor Salman just said that with the new multimedia and other avenues that you can consult anybody, anywhere. And I know that our current speakers and experts are always willing to support you, to guide you, to help you. I've always gotten the help if I needed one. So, and in Karachi, I get the help from Dr. Professor Shahnaz and other friends here. And I'm pretty sure those who are away from Karachi can use the media assistance better. And with that, I must thank the speakers, the discussants, and so on. Thank you very much.
Thank you so much, panelists, for your valuable comments. I just want a brief comments from Dr. Tipu Sultan that we have discussed that the drug should be tapered slowly, that we know as a pediatrician and Peads neurologist. We saw in our practice that the switching of the new drugs, the few drugs, the one drug is given for a few days and then the treating physician switch to another new drugs without closely observing the outcome of the previous one. So what should be the strategy in this case if child is visiting in our clinic and we saw that the few days back the child has another drug and now the child has been prescribed and some other drug. So can you please guide the participants? Mostly the participants are general pediatricians. So what should be the strategy in this regard?
Thank you, Dr. Shazia. You raised a very important and pertinent question in the management of childhood epilepsy, apart from infantile spasm or West syndrome. Perhaps this is the most important and ignorant component in the management of children with epilepsy, because giving a trial of anti-epileptic drug is not a good approach. And the principle since long in the management of epilepsy is go slow and go low. So you should add one appropriately chosen drug according to the epilepsy syndrome, build it to the maximum therapeutic level with either seizure freedom or arrival of side effects. So whichever is first. So either side effects or complete freedom from the seizure. But you should not exceed the described therapeutic level or described dosage in the literature. So for example, valproate sodium or levetiracetam, or say for example in the management of infantile spasm, vigabatrin, the dose is maximum dose is 150 milligram per kilogram per day divided in 2 dosages. So one should not exceed from this. However, the starting dose is 25 to 50 milligram per kilogram per day. If a child is fully seizure controlled with, let's say, 50 milligram per kg or 100 milligram per kg, then there is no need to exceed further. However, in contrast, if a child had side effect of any drug, either at the start with the lowest therapeutic dose, then this would be an indication to discontinue that particular drug. In other scenario, if there is more than 2, 3, or 4 drugs in case of drug-resistant epilepsies, then perhaps, as mentioned in the initial conversation discussion by Professor Shahnaz, then probably the latest efficacy drug with latest, lowest efficacy, or drug which has maximum potential side effects, or a drug which has lowest therapeutic range in case of serum level, because we rarely advise serum levels of the drugs. But if a drug is totally under therapeutic level, then probably that would be the drug which have to be eliminated from the long list of anti-epileptic drugs in the first instance.
Thank you so much. Thank you so much for such a detailed answer of this question. We have few questions from the participants, so it's the turn for the participant to ask. This is the question from Professor Salman Ali. उन्होंने पूछा है कि is the video EEG facility is available in Islamabad, sir? Do you know this?
Does this child was asked by Professor Salman or from Professor Salman?
I'm asking from Professor Salman Ali because he is Islamabad based. So if he knew that, it might help the participants. They want to know this.
Yes, I think video EEG facility I haven't come across, at least in the military setup. It's not available. Maybe I think it might be available at Peshawar, but in our facility it's not available.
Dr. Salman, I don't think it is available in Islamabad. Maybe Tipu, you can answer
Yes,
that.
I think
also.
I have no idea.
I don't think so, because I know of a couple of patients who've actually been referred here for the video EEG. So I don't think it is available in Islamabad. Maybe I can check and let them know, whoever is asked, if you can email me. Dr. Arsalan is at Shifa. He's an adult neurologist. We don't, except for Dr. Matloob, who is not really actively working now. I think he does work at some peripheral hospital. He's the other pediatric neurologist where he would know.
No, Professor Matloob, he just retired from that hospital.
Okay.
So probably he is not in.
He runs his own practice, yeah.
Sir?
He has his own clinic.
Yeah, he's
runs his
running
own
his
clinic,
own clinic, but he's not working in any hospital right now.
Yeah, he's not working in any hospital.
Yeah. So probably, as mentioned by Professor Shahnaz, probably Shifa International Hospital would be the only option. We may ask Professor Arsalan or any colleague from Shifa International Hospital.
So there is another question, the role of vagal nerve stimulation, particularly for infantile spasm. Dr. Shahnaz.
I think, as mentioned in the first presentation by Professor Shahnaz, it's a treatment of choice for drug-resistant epilepsy, or in which all the drugs are failed. However, its role is yet not established in the management of infantile spasm. However, when there is no option, then maybe a desperate physician may try it. But at the moment, there is no standard recommendation for vagal nerve stimulation in children with infantile spasm. I think Professor Shahnaz can also comment on it.
No, I agree, Tipu. I think vagal nerve is predominantly for atonic seizures. And so if you have LGS or atonic seizures, then vagal nerve stimulation and even cortical stimulations are one that you would use, but not for infantile spasms. Ketogenic diet works for infantile spasms. Yeah.
You mentioned about
deep brain stimulation.
You mentioned about deep brain stimulation. One of my patients who was in fact a challenging task for all of us, and during recent visit of Professor Sami Zubairi from Glasgow, I also invited all those difficult cases for his opinion as well. So they have been experiencing this deep brain stimulation from one of the adult neurosurgeon who is actually doing this procedure for generally for dystonia, but they opted for this procedure out of desperation, and it helped maybe partly up to 40 or 50% seizure reduction in that particular child. He's a grown-up child now, about 10, 12 years, but all the drugs almost failed in that particular child. So these are some of the challenging cases we had. So I would like to take Professor General Salman's take and Professor Shahnaz take. When we have no success in managing these challenging cases with any of the anti-epileptic drug, what would be your recommendation about these new drugs which are classically not recommended for these difficult cases? For example, vigabatrin is in case of atonic seizures. Professor Shahnaz?
So vigabatrin is more for focal, and I have used it sometimes when they're extreme, the myoclonic ones, where they keep getting this, the kind with epileptic encephalopathies. Remember, these are genetic conditions, and we have not started reporting a lot of these progressive myoclonic epilepsies. We see a lot of progressive myoclonic epilepsies, which are like lipofuscinosis and Laforas, which we are not, we can diagnose them now with biopsies, but again, with the genetics and all. These are progressive. Whatever you do, you will not do anything. I've tried ketogenic on it, and now I'm getting the results, so the UCL team had come over and we sent the genetics. Now we are getting the results of those, and a large percentage of those are just untreatable. You know, I tried KD on them also. They did respond partially, like 50%. I said, you know, so the overall rate of recovery was 50%, 80% went down 50%. That's also a lot, considering, you know, the type of seizures that they have. But to say that the new drugs, well, there are, you know, people have tried over here, the adults, put them on rufinamide, especially if they are 14, 15, rufinamides, and even zonisamide. Zonisamide is available now, and so is rufinamide available. So these are the newer drugs which people are using, but it's very difficult to, very expensive, and very difficult to continue on management. Even cannabinoid is very expensive. You know, the starting dose for a 10 kilo individual would be costing around 20,000 rupees, not less, per month. And they don't mention the amount that is there per ml. It's written 1,000 milligrams / 30 ml. Whether it's in 30 ml or whether it's in 1 ml, whether it's in 2 ml, you know, nothing is there. Nothing is written on it. Whether it has the preservative, which is there is a THT or a DHT, which is supposed not to be given, which is actually damaging. So, you know, these are difficult, and I'm very skeptical about using something which has no label, proper label on it. So it's only one patient that I actually used it in infantile spasms only, and they didn't respond. And now I've started the keto on that child. But so it's not an easy question. The intractable epilepsies, even infantile spasms, sometimes they like even TS. You know that vigabatrin is the drug of choice. You would not use anything else. But sometimes they just, because of the tumors developing, you know, they just tend to get very, very difficult to control. So it's a tough one. And so Tipu, when you said that he underwent deep brain stimulation, this is something that they can do, you know. And deep brain stimulation, and if the quality of life improved by reducing the seizures to 50%,
exactly.
So be it.
And
So,
reducing the drugs. Not only reducing seizure, but reducing
so at
the
least
drugs.
the somnolence and the side effects of the drugs was less. But I think you know, the way that the world is expanding and the access to things, it's not going to be long before we start. They've started deep brain over here for dystonia, but particular type only in Parkinson's and adults. And I'm trying to twist their arm to do it in a couple of my genetic dystonias. But because it's new for them also, so they don't want to try it at present.
What about vagal nerve stimulation? Is it available in?
I don't know. I think somebody said that they're trying to get that across over here.
Exactly.
Again, you need to have a good medical services available with it. You know, sometimes when these machines, especially also with the deep brain stimulation, if they crack, the wires crack, you can go and do a status, even with the vagal nerve. If you sort of break the connection and the connection breaks, if the child falls and breaks the connection, you should have immediate, it's an emergency situation where the child would go into status. And so it's very difficult. Same goes for the baclofen pump, which you use for spastic diplegics or spastic quadriplegics. You know, these are very, you need to have special services available in your general pediatric neurology. And I call myself a generalist now. I'm not a specialist. We are all generalists, really. And so to deal with these complex issues, you need to have a very specialized service where you see only 5 patients in your clinic, which is just not possible, you know. And I'm seeing way less than you are, and I get overwhelmed with what I'm seeing. So it's just not possible for you to, you know, jump from one patient to the next, and the third, and the fourth, and then keep thinking about what happened. You know, that thing broke, and then it's an emergency. So we need to get our priorities, and I think we're doing as best as we can. And I think keto should be developed. I'm a strong proponent of ketogenic diet. I think I recently have started it on SSPE patients, and they're all from interior Sindh. Now, so we have to write it down in Sindhi for them. And so now I'm trying to do LGIT, and I'm not doing KD because KD is very difficult. And today in the morning I had a discussion with the Mamu, who's the only literate person in the family. And so I had to literally, make him read and tell me and measure कि वो कितने cup में कितना डाल रहा है to actually be sure that he's doing the right thing. So it's difficult to do this, but you need time for this. You can't just, sort of have 100 volume and then say, okay, you are doing these very, very highly specialized things. So it's not, even KD is in the West, they have epileptologists who are just doing KD, okay? Only KD. So, imagine their, changeover and their exposure, and they're not doing any other epilepsies except managing KDs. So it's difficult for us to try to juggle and do this.
So, very right, madam. It's very difficult to treat each and every aspects of neurology, and every aspect is time consuming. It needs
exactly.
It's
not a 5-minute job.
There is a question from a participant. So, epilepsy surgery is option, but what is the prognosis and outcome after surgery? Will the seizure threshold decrease, or patient can be a seizure-free if the focus is removed?
So if you have a lesion, and like for mesial temporal sclerosis, I have had families where they were on like one of the children, the mother had it and the child had it, and so it's focal epilepsy is also a genetic, and I have another family like that where the mother has it and the child has it. Both have the mesial temporal sclerosis. In the second family, they're only on one medication, so I won't push them for any surgery. But the other family, the child was on 4 anti-epileptics. So the mother underwent, and mother was also on 4. Mother underwent the surgery first, and she came down to only 1. And then the child underwent surgery. This I'm talking about almost 10 years ago. I don't know what their genetic panel is, but he became seizure-free, but he was also on 1 medication. I haven't seen him back in at least 4 or 5 years. The other family I'm following, they are a genetic TCBD, something like that gene, which is related to focal temporal epilepsies. And it can be frontal, it can be temporal, anywhere. So they are not on the list for, because the seizures are very infrequent. He's very well controlled on 1 medication. So it depends on the type, the intractability. If he's on 3 and 4, then you would definitely think about, and of course you also have to think whether it's the dominant area or not. You might hit the speech and then, he's left with no speech. So you have to be very careful. And of course, if there is a lesion, if it's a tumor, it's a mass, it's an aneurysm, you're going to go and remove it.
So there is another practical question, I think, that which has been asked by our participants. Some pediatrician, if you start valproic acid before 2 years of age and the seizures are controlled, so do the treating physician need to stop it or have to continue with the valproic acid? Suppose if it is started at the age of 7-8 months.
I'll let Tipu take this.
I think the standard practice and standard advice is not to start valproate sodium before 2 years of age. And even in the UK and NHS guidance, they don't recommend valproate sodium in adolescent girls, maybe after the age of 12. So one should be very careful by definition. Second is about local circumstances. We don't have many options previously, though there are a lot of new anti-epileptic available in the recent past. However, in the traditional pediatric neurology or per se pediatric practice, we have very limited options for majority of our population. So in those circumstances, valproate is perhaps one drug which is a very broad spectrum and can control all groups of epilepsy syndromes and generalized tonic-clonic, absence, myoclonic. So that was the reason valproate is being practiced and prescribed in almost all age group and both genders. The specific question was about its indication in younger children under the age of 2 years. So in that case, probably levetiracetam and carbamazepine is more favored and safer drug. However, it again depends upon the underlying epilepsy syndrome, because myoclonic seizures or atonic seizure, it's not very ideal to prescribe carbamazepine, which is otherwise safe. So the remaining drug is either levetiracetam or maybe oxcarbazepine in that levetiracetam or maybe some of the other new drugs. Or oxcarbazepine is though a good drug, or carbamazepine or oxcarbazepine is a good drug for children with under the age of 2 years, but not for myoclonic or absence or atonic seizures. So phenobarbital is though good choice for the children with hypoxic ischemic encephalopathy and children with the generalized seizures, but again the problem is with its availability and its long-term side effects. I still remember during one of our meetings with Professor Shahnaz, these days phenobarbital is not practiced in majority of children beyond neonatal age. Professor Shahnaz, would you like to comment upon the indication?
So, you know, when you start them on pheno, you would want to take them off if they are seizure-free by 2 years of age or even earlier. So if they have had a seizure, single seizure in the neonatal age group, and somebody's put them on phenobarb, and the kid is doing well and had some hypoxia or mild or grade 1 or whatever, you can try to take them off within 3 to 4 months. If the EEG was normal, the kid is developing normally.
Yeah.
But
As
phenobarb can,
possible.
but phenobarb can be given up till 2 years. So under 2 years, I would, if they're closer to 2 years, then I would not take off the valproate. If they are way less than 2 years, then I would switch them. If they are having seizures, then add phenobarb and then see. Phenytoin is a good drug to be used under 2 years also, and it would cover all your generalized epilepsies. However, the oral form doesn't work in babies. It somehow doesn't, you know, you don't get levels. So if they come into your emergency, you have a seizure and you have IV available, you can use phenytoin. But if it is an oral, you cannot switch it to oral. I don't see good levels. And somehow in pediatrics, the oral formulations don't produce good levels. So no, for phenytoin as an oral drug.
So it means, madam, recommendation for a pediatrician working in periphery, if a child came with the status epilepticus and he controls his seizure with the, for example, oral injectable phenytoin, so then a drug of choice he had for subsequent seizure control is either valproate, carbamazepine, and levetiracetam.
I think phenobarb would be, you know, if he's less than 1 year old, then I use phenobarb. I would use phenobarb. I would put him on phenobarbital because, and you know, of course, checking the availability. That is the problem with phenobarb. It just sometimes disappears, but it's the cheapest drug. And so if you are working in the periphery and the cost is also an issue, then phenobarb would be something very easily that you can give. And you can give them rectal diazepam also with it, like you showed in your slide. So that would be something I would recommend.
But availability is always an issue.
Yeah. So, you know, that is the sad thing. That is the sad thing because, you know, every form of levetiracetam is available. I don't know why drug companies can't go and make valproate and phenobarbital or even carbamazepine in local formulations which are available and easily accessible. It's just that it's so cheap, they don't think that it is worth it, I think. So phenobarb should be made locally, I think. You know, it is available locally, but it sometimes disappears.
So Dr. Shazia, any other question?
I think we took enough questions and the answers.
Shazia, I think I saw one question and I want to answer that. Somebody asks about the pyridoxal 5-phosphate. And so what I would like to do is tell them that the PNPO is the enzyme, the oxidase, the pyridoxine 5-phosphate phosphate oxidase is the enzyme that is required to convert the pyridoxine into pyridoxal phosphate. And that is the active form which goes into the cell and in the brain, which then works. So if your pyridoxine is not working, you can use pyridoxal phosphate directly because that may mean that it is not the anticotin and it is actually the pyridoxal dependent seizures, this is not something which is like the body, the AASA is destroying your pyridoxine, but it is actually a deficiency. So you can try pyridoxal phosphate, and it comes in powder form. I think I have asked my pharmacy a couple of times to have it made. Because it is enzyme based, so I don't know exactly the gene for this, but probably if I haven't seen any particularly diagnosed it in that form, but if the pyridoxine doesn't work, you can try pyridoxal phosphate.
So thank you so much with this all discussion, and I have learned a lot, and I hope that the participants will also learn from this event, and their queries have been properly addressed by our experts and panelists. I would like to thank the panelists, especially Professor Salman Ali, who stayed with us till the last, and my experts, those who gave us their valuable time and share their experience and knowledge with us. And also Professor Amin Jan Gandapur, he is perhaps on the way to somewhere. His video is visible. So it was very nice event, and I learned a lot from everybody, my senior neurologist and my senior pediatric faculty over here. And thank you to the Genix Pharmaceutical who arranged this academic event for us, and the participants who participate actively in this session. One thing I want to announce sort of for a pediatric neurology, that we have an upcoming pediatric neurology conference in Multan in month of the February. So I would request to everybody in the participants, they should try to attend it, and it would be a good event, and it will increase and enhance the knowledge related to pediatric neurology. Any comments from my panelists, concluding remarks from my panelists and the speakers would be welcome.
I think this has been, sorry. Yes. I think this has been a very, very stimulating session with our panelists and participants. Professor Shahnaz Ibrahim and Professor Tipu Sultan really made a difficult subject very easy, easily understandable, and did justice to this difficult area and answered the questions very astutely. And I think Professor Iqbal Memon and Professor Amin Jan, my fellow panelists, they also really chipped in very well to make the session very, very stimulating. And we thank all the participants, and particularly Genix. And we also thank you, Dr. Shazia, really being a very wonderful moderator and conducting the session in a very, very expert manner. I think although we are online on Zoom, it appears that we are just sitting across each other. And I think really I enjoyed this session. It was really very wonderful to be with.
Thank you, everybody. Thank you, Professor Salman, Professor Memon, and Professor Amin Jan for being here. Thank you, Shazia. My colleague, Tipu, thank you for always being there to help me, support me. And of course, Genix Pharma for, I think, bringing in vigabatrin is going to be amazing for all of us. And it's prescribed as VLAP. But I think, I would always be very, very frustrated because you start the vigabatrin, it's not DRAP approved, and then the pharmacist would charge whatever they wanted to charge. And so I am really, really grateful to Genix for introducing this very, very important drug in our community. And as pediatricians and pediatric neurologists, I think both Tipu and I, and Shazia, I'm sure, are extremely grateful for having this medication with us. And we hope that it won't disappear on us. So, this is going to go a long way in helping our children, especially the ones with infantile spasms. And I think that is the commonest intractable epilepsy that we see.
Yes.
So that is, more than otohara, more than early infantile. Infantile spasm is like your bread and butter of intractable epilepsy. So thank you very much again, Genix Pharma, for procuring this and doing all the work and getting it across.
I think I will second totally Professor Shahnaz. Before the official arrival of Vigabatrin in Pakistan, a couple of my patients buy this 20,000, 25,000 or 30,000, and once they bring it from West, UK, US, or maybe from the Middle East, and in the one good night, the stock finished, and then we are in a mess how to proceed further with either Vigabatrin or steroids or any other anti-epileptic drugs. So probably with the continuous regular supply in the shelves of medical stores of Pakistan, so probably we'll be in a better position to control all these children with infantile spasm or West syndrome or per se drug-resistant epilepsy. So that's why I was asking specifically about, say, its indication beyond infantile spasm and West syndromes, particularly in some of the mimicking conditions like Lennox-Gastaut or early epileptic encephalopathies or otohara or Dravet, which are generally presented with the same kind of epileptic spasm with more or less same age group. So, however, in short, the bottom line is we have one new drug available as a licensed medicine in our medical stores for our children who are either with the infantile spasm or West syndrome. And second, this was a nice opportunity to see General Salman, Professor Iqbal, Memon, Shazia, you, and Madam, of course, you. So it was a nice, wonderful afternoon with you all on this very chilly kind of weekend in the end of January. Thank you, Shazia, for being a very nice host, and
thank you, Dr. Salman. Lovely meeting you.
For your new department. Thank you, General Salman and Professor Iqbal Memon. Thank you, sir.
Thank you. Allah Hafiz.
Allah Hafiz. Allah Hafiz.